ahead to introduce myself. I'll be presenting a research from my organization. I'll go ahead, introduce myself, and then go into the slides very quickly. So my name is Oluchi June Ifeanyi. I work as the Research Monitoring and Evaluation Officer at the Initiative for Equal Rights. The Initiative for Equal Rights is a Nigerian-based LGBTQ-focused human rights organization, and our work covers three core pillars: research and knowledge management, human rights and advocacy, and health and wellness. And then the project I would be giving an overview of today is based on our health and wellness pillar, because we have a HEFAMA-approved clinic in Nigeria where we provide general healthcare services, HIV prevention, testing, management, malaria, the whole spectrum of healthcare services to LGBTQI individuals in Nigeria. Okay, so okay. So firstly, I wanted to go and do an overview of our mission at TIERS. Though I mentioned that we offer three core pillars, but I wanted to highlight that we want to make it possible and ensure that LGBTQI individuals in Nigeria have access to dignity, safety, and quality healthcare. And that's fed into this project implementation, which is called the Nigeria LGBTQ Consortium project. So this project is a national partnership led by TIERS, working with 5 other community-based LGBTQ organizations in Nigeria in 4 geopolitical zones to basically implement a consolidated, and I know we've heard this word a number of times during the course of this session, but an integrated HIV service provision model to ensure that it's not just a case of just providing HIV testing and management services, but also integrating that very crucial aspect of mental health provision. Because it's not just the physical that makes one healthy. We had to also recognize the fact and also put this into play that there's also the mental parts that also contributes to the physical health of individuals. So this project is funded by the Elton John AIDS Foundation, and then this project kicked off in January 2024. The aim of this project was to scale up access to HIV and mental health services, reduce vulnerability, and advance health equity for LGBTQI persons in Nigeria through community-driven inclusive programming. So I mentioned that we have a HEFAMA-approved health clinic in Nigeria. So I would say we are very experienced in providing HIV services to marginalized population, key population in Nigeria. But we needed something because in addition to having like a clinic where we provide services, we also conduct outreaches as an organization. So our medical team, our clinic team basically goes to like community centers to basically also take this HIV testing and management services to members of the community and not just wait for people to come meet us in our clinic. And then we noticed one very key barrier. There was not that community aspect of it. It just seemed like, oh, TS. So this is HIV service model that is community driven, and that is the highlight of this session, basically highlighting the impact of community in advancing viral load coverage, viral suppression in LGBTQIA individuals in Nigeria, and basically improving the impact and outcomes of the services which we already provided in the past, but we now took it up a notch to cover various members of the community which would have ordinarily not been able to access based on they're not, like I said, they're not being that community based in implementation. Okay. So the outcomes of this project was improved access to comprehensive sexual reproductive health and mental health services, like I mentioned, and also reduced social vulnerability for LGBTQ persons in Nigeria. So I'm going to give a brief context before we proceed. According to UNAIDS 2024, there are 22 million people living with HIV in Nigeria, and that covered 48,000 new infections in 2023 and then 42,000 age-related deaths. But then there is now another layer of barriers for key populations, especially LGBTQ individuals in Nigeria. There's the legal restriction of the Same-Sex Marriage Prohibition Act, which criminalizes LGBTQ identities, creating fear of arrest. So there's been the entire discussion of, okay, how do we make HIV service provision more accessible to people living with HIV? There's a lot of barriers that have been shared in the course of this conference. But then when there's now an added layer of discrimination or stigma or basically targeted state-backed violence on LGBTQI individuals, that basically adds a level of barrier to adherence for LGBTQI individuals who are living with HIV. So, like I mentioned, stigma and discrimination. According to the UNAIDS 2024 report, 52% of adults will not buy food from someone living with HIV. 47% believe children with HIV should not attend school with others. There's the access gap, like I mentioned, for key populations. Men who have sex with men, the ART coverage is only 26%. Transgender people, the HIV prevalence is 28.8%, and ART coverage is just a measly 19.5%. For sex workers, there's the ART coverage of 23.7%. And then there's now an added layer for majority of the community members, which is the economic barrier. So poverty and transport costs reduce treatment access. For instance, if you've not had food to eat, or if you don't know where to sleep, or you don't have like your basic needs as a human being to exist, taking your drugs or going to like a facility to access drugs is going to be like one of the least things on your mind, one of your lowest priorities. So that's also another barrier for key populations accessing HIV services in Nigeria. Okay. So this community-led HIV intervention, which falls under the Nigeria LGBTQ Consortium project, like I mentioned, is being led by TIERS, and then we work with 5 other partners in Nigeria, located across 4 geopolitical zones. But TIERS implemented our own strategy and implementation in Lagos State, and our project supported 298 clients. This community-driven discussion that I basically started is set around 4 pillars, and these are the 4 major pillars for our implementation in Lagos State. The first one was transport stipends. The second one was SMS reminders and client tracing. The third was key opinion leaders-led outreach and testing. And the fourth was VCAT training for healthcare workers. I'll go through them one after the other. So the first one was transport stipends. Remember how I said, somebody who has not had food to eat or doesn't know where to sleep or doesn't know where their next basic amenity is going to come from, the least thing on their mind is going to be, let me go to like a facility to access drugs, which is important because you cannot overemphasize the importance of taking your drugs or going for viral load testing or basically being adherent. But it wouldn't be the top priority of somebody who doesn't even know where they're going to get their next meal from. So we decided to provide support in that manner by providing transportation reimbursement for 23 economically disadvantaged clients. And then this enabled access to ART refills and viral load testing despite financial hardship. So we did recognize that, people actually found it hard basically because of the economy. And then we wanted to integrate an aspect where we could support to ensure that even though we didn't provide food, we basically make sure that it was possible for them to get to the facility to access their medications and also their testing requirements. And then the second pillar was SMS reminders and clients tracing, like I mentioned. So we sent quarterly SMS reminders and follow-up calls to encourage adherence. We did lose 10 clients to follow up, basically due to unreachable contacts or they relocated abroad. But firstly, let me just highlight that we were working with more of, I would say the model we were using before was not as intense as this method of SMS reminders, call reminders, and also trying to trace clients if we could not reach them via SMS phone calls. So this made it more possible because we sent out BCs about the importance of adherence. We sent out BCs about the importance of viral load regular viral load testing rather, and we also did like follow-up calls to like clients to basically remind them that, oh, please remember that the date for your viral load testing is this day. Please ensure that you make out time to come. Please remember that, oh, you need to pick up like your next set of drugs on this day, so please make out time to come. And I would say that also increased the number of people who remembered that, oh, they had to come to like the facility to access their drugs and also get their testing done. The 10 clients that we lost to follow up, those were removed from the system because at the end of the day, they were just literally buffer numbers to the clients tracing that we were doing. So after a while of not being able to reach them, we removed them from the system, and then we proceeded to follow up with the remaining clients. The third one was KOL-led outreach and testing. So like I shared earlier, KOLs are key opinion leaders, more like peer educators. So remember how I mentioned that TS owns a clinic and then we also conduct outreaches. But one very important challenge that we needed before implementation of this project was there were some hard-to-reach locations in Lagos that we couldn't access because we're not part of the community. So one very key thing we did was we had to find key opinion leaders of LGBTQI individuals in these hard-to-reach locations. And then the roles of these key opinion leaders was not to say, oh, if you know anybody that needs services, bring them. No. We had to train them on how to be community testers. So this training was done by Lagos State AIDS Commission Agency, by TS's medical doctor, basically making them community testers that could organize and hold outreaches by themselves within their communities. So that means we expanded the service service band of people accessing HIV testing and services. So not only did that empower people to be able to access services in hard-to-reach regions, this also made it possible for people to basically get these services at their doorstep. Well, we are located at Lekki. Okay. We were located at Lekki, and we kind of understood how maybe it was difficult for some people to access. So this particular service of basically training 20 community health testers, and then we actively engaged 15 on a monthly basis to conduct outreaches. So on a monthly basis, 15 of those trained community testers conducted outreaches within those hard-to-reach communities. And then we found that the numbers and the people we couldn't reach because of, either they couldn't come to our clinic, or when we did go out for like medical outreaches, we couldn't reach them. We started reaching those people. And then whenever there was any reactive person identified during these outreaches, they were referred to the clinic. And that also fell under the number of people we supported with transport reimbursements. So after being identified as reactive, there were some cases where some people mentioned that, they couldn't access they didn't have like transport to get to like the facility to be like properly enrolled in care and properly linked to care. And those were the part of the people that we supported with the transportation reimbursements. So overview of the data under this pillar, there were 20 community testers trained from identified key opinion leaders. 15 were actively conducting monthly outreaches. And based on that, 1,556 individuals were reached, 61 reactive cases were identified, and 23 escorted to care by peers. So that means they didn't just identify them and say, okay, that's the location of this clinic. You can go there if you need to access services. There was actually these trained testers actually escorted some of the reactive cases to the clinic to access care. And the impact of that was expanded reach to hard access communities, like I mentioned. It builds trust because it's not like, it's an organization that is coming to test you. You don't know where the organization is from or where they are using like a service or the other. This was like a community member you are familiar with, a community member that you just meet and you like having one form of gist or the other. So they really felt comfortable, collating together to access services. If they had any issues, they felt really comfortable speaking to the community member because that person was literally one of them, and it also improved linkage to care. And then the last one was VCAT training for healthcare workers. VCAT means value clarification and attitude transformation, and we did this for public hospital staff. So remember how I mentioned that we have one clinic which was in Lekki, Nigeria, and we understood that it wasn't feasible for everybody in Lagos, all the LGBTQ individuals, especially in Lagos, to come to our clinic to access services. We needed to have more referral points where we could refer people to access services. Yes. And a number of feedback we've gotten over the years, which is why we have tried to expand the level of services we offer, but at the end of the day, we still can't cater to everybody, was that a lot of people don't want to go to public health facilities because there's the stigma, there's the discrimination. Even though you are going there to access like essential medical health care, there's the conversations, or you go there, somebody's preaching to you that why are you gay? You go there, somebody's telling you that this thing that you're doing, do you know that it's going to lead you to hellfire? You go there and people like healthcare workers are making snide comments or snide remarks about you. And you're like, is this what I came here for? So this value clarification and attitude transformation training was basically a training where we gathered healthcare workers and we basically looked into all their values and all their biases and all their preferences and let them know that it's very valid that you have your biases. It's very valid that you have your preferences. But it's also very, very important that you don't let your biases or your values or your preferences to get in the way of the service you have to deliver. You don't let your biases dictate, oh, this is the person I'm going to attend to. This is the person I'm not going to attend to. If a sinner comes to meet me, I have to preach to this person first because that is what my values tell me to do. That is not why we are here. So we basically let them know that though you have your values, your biases, and your preferences, it shouldn't get in the way of the work you have to deliver. So based on that activity, we trained 30 healthcare workers across 8 general hospitals in Nigeria. And then it didn't just end there, because in the training we'll do pre and post, but it didn't just end there. It will definitely show that, oh, maybe there was an improvement in this. People now know more about subjects, issues, and how to handle or provide inclusive care for LGBTQI individuals. We actually sent clients to these facilities where we sourced these 30 healthcare workers from to actually let us know and assess what would you say about the quality of care you received. And then we referred 21 LGBTQI clients to these facilities, and they assessed PrEP and PEP via referrals. And they did get back to us with the feedback that the service was warmer, the reception was warmer from these healthcare facilities where we trained healthcare workers, and the stigma was reduced. So the impact of that, like I said, was reduced stigma in public hospitals and expanded safe LGBTQ-friendly referral pathways. So that means we didn't just reduce the manifestation of people's biases and values in their service provision. We also now have about 8 different hospitals across Lagos, apart from our facility, we can recommend LGBTQI individuals to go to access care. Okay, so what did this lead to? The blue stands for before the implementation of this project, and the orange stands for the current progress. Viral load coverage before implementation was 79, and after implementation of this project was 98%. And then viral suppression before the project was 97%, and after suppression was after implementation was 89%. And I know a number of people would be asking, oh, since this is such an innovative way of providing HIV services to the community, why is the viral suppression after implementation lower? But a number of reasons would have contributed to that. Number of reasons such as, like I mentioned, economic challenges, people who relocate a lot and have to move from our facility where we are tracking people living with HIV and then their viral loads to other facilities where we can't reach them. Or there might also be the issue of people who have recently been lost to, who we recently lost to follow-up, or they were no longer enrolled in care, came back into care, and the viral load was like extremely high, and then it couldn't like contribute into the data of viral suppression. And I also wanted to mention one last one. There was also the cases of a lot of people just being newly enrolled into service based on they just being newly identified during outreaches. So they would definitely not have contributed to this percentage of viral suppression. So these results, what are the results of the 4 pillars which I just explained? Like I mentioned, 298 clients were supported. There were 23 transport stipends. 1,556 clients were tested during peer educators or KOL outreaches. There were 61 reactive cases and 23 were escorted. And 21 clients accessed PrEP or PEP in partner referral facilities. The lessons learned were socioeconomic support such as transport stipends, SMS follow-up, boosted retention in care. And then the community ownership and peer leadership expanded reach into hard access communities. The VCAT trained healthcare providers reduced stigma and improved service experiences in public facilities. And then co-designing with the community built trust and ensured sustained engagement. So we could have said that, we've been providing services for HIV, LGBTQ individuals who live with HIV for years. We know what works. But then going back to the community and asking them, what do you think is the best way to implement? And then we're not now saying, since we are such experts, I've been providing services for over 15 years, let us now advocate or implement on your behalf. But we actually ensured that they were the ones who led implementation and led service delivery, and that also contributed to the high impact of this project. Okay, so how does this inform basically the catalyzing integrated sustainable responses, which is the theme of the ICASA conference? So like I mentioned before, the community mobilization ownership promoted trust among our target population, which is the essential ingredient for long-term engagement and health-seeking behaviors under restrictive laws like the SSMPA. Social support such as stipends address the structural barrier of poverty, demonstrating that socioeconomic support is critical to sustain ART adherence. Clinical care such as viral suppression, data-driven practice, implemented by removing inactive clients and prioritizing follow-up, ensured program resources are focused on those retained in care. And then through health service provider sensitization, there was an expansion of the network of safe public health facilities, reducing reliance on community-based clinic alone and ensuring continuity of care. The integration of social, structural, and clinical responses ensured a holistic and resilient model. So our next steps here would cover expanding the model to additional Nigerian states. So like I mentioned, this was implemented by tiers in Lagos State, Nigeria. And then this would also be adapted to local context under the SSMPA constraints. Another activity would be to evaluate the cost effectiveness and long-term retention outcomes. Because how many people can we actually support with transportation reimbursements? Is there a need to maybe add a section of actually equipping people with skills where they can actually fend for themselves, as long as planning to map out, this is how much transportation reimbursement we are going to be giving to every client who comes to our facility. And then there's the third one of we integrate this model into national HIV service guidelines in collaboration with state control agencies. The model of community-driven is the way to implement, especially for HIV service delivery. There's not a case of we bring community members to the table, let them tell us what they want, and then we'll go out and implement on their behalf. People living with HIV are very capable of advocating for themselves. They are very capable of implementing activities on their behalf because they are the ones that knows where it pinches the most. So they should be prioritized in the implementation of activities surrounding HIV care. Okay. Conclusion and call to action, basically. Viral coverage rose from 67 to 95%. And at some point during our data analysis, it peaked at 99%, which was in February. Viral suppression achieved 89% among those tested. Our commitment is that we remain dedicated to LGBTQ health equity and rights-affirming HIV care. And we are calling for you to scale and sustain this model across Nigeria and beyond with us. Together we can catalyze integrated, sustainable responses. Thank you. Okay, so does anybody have any questions? Another speaker here. Please. So the speaker that's supposed to go after me. Okay. Okay, so please confirm you've shared your presentations with the IT team or confirm they have it. But does anybody have any questions in the meantime? Questions. Okay.
Yes, thank you very much for that great presentation. My name is Rachel Ufuriata. I wanted to find out if you are considering scaling up the training you had with the health facility workers. As I imagine, you have a lot of public health facilities in Nigeria. Thank you.
Yes, so one way we are thinking around doing that is basically working on a course as opposed to like training people. So we work on a course and then we get it integrated into agencies like National AIDS Control Agency, which means that as a healthcare worker, if you are just hired during your onboarding process and before you start basically providing services, this is like a course you need to go into that covers subjects and inclusive service delivery for LGBTQI individuals. So we do, because we know that over the years, for so many years, there's been training of healthcare workers back to back, over and over. People leave healthcare facilities, new people are hired. But then the discussion of how can that be sustained. So that's a way we're trying to look into establishing a system where instead of having trainings where we gather just 30 people or we gather just 50 people or 20 people and then we can't even cover all the public health facilities, we're looking at something that is more sustainable in the long term and also is cheaper and more accessible to like everybody who basically is hired into a new facility and gets to provide services. So that's what we're thinking around that. Questions?
All right. Good morning. My name is Paul. Just 2 questions. How did you measure your reduce stigma? Because I saw your presentation, you're talking about reduce stigma amongst the healthcare workers. So I want to know which method or tools that you use for this. And then my second question is, how do you also track clients' mobility, knowing that transport refund to clients is an incentive? And clients may want to move from facility to another facility just for that transport stipends. How do you track this mobility? Thank you.
Okay, thank you very much. So firstly, we basically created a checklist for the people living with HIV. So we let them know that, we are actually sending you to these healthcare facilities for you to get services, but also assess the level of stigma and discrimination based on the individuals you interact with. So we basically drafted a 4-question stigma checklist, which we shared with them, and then we got data from them after they got back from the facilities, and then that's what fed into data that I mentioned about reduced stigma and then reduced discrimination in these facilities. And then for the second one, I would say not every facility offers transportation reimbursement. So yes, while they might want to move between facilities to access transportation reimbursement, they would have to know which facilities are offering, which I wouldn't say they are like so much in Lagos, Nigeria, or Nigeria as a whole. But that was just being added to our own implementation because we understand the specific layer of economic challenges that LGBTQ individuals would face based on their sexual orientation and gender identity. They find it harder to retain jobs. Once people find out their sexual orientation, they find it hard to retain houses because people have actually been kicked out of their homes because their landlords or their neighbors found out that they were queer or they were gay or they were lesbian. People have been outed by their family members and basically gotten all form of financial and economic support cut off from them because they are literally gay or they are literally lesbian. So we do understand the added layer of economic hardship that a lot of LGBTQI individuals face, which would not have been the case if they were straight. And then that's why we added that layer of transportation reimbursement. But I'm not sure of so many other organizations who provide transportation reimbursement to come to the clinic to access services. So yeah, that's how to answer that here. Okay. Yeah, so while I'm answering, please let me know when I think I'm done. So the next speaker can signal. No, sorry. There's a question here, but I'm just saying so I don't spend the entire time answering questions. Just let me know when you are ready, and then I'll introduce you before you come up. Okay.
This is...
Okay. You can.
So, for me?
Yes.
Okay, mine wasn't really a question. My name is Sheikh Traore. I'm actually based in Lagos, a board member of CPHI. In this conference, I learned that there's a great idea for mainstreaming. You were talking about integration and mainstreaming trainings for healthcare workers. In Ghana, they've tried to integrate the course on human rights, HIV, partnering with key populations with nursing schools. So it's a project that is ongoing, which I think is brilliant because you you integrate your course into the nurses' curricula, and it just runs by itself. So all healthcare workers are trained, and you don't need funding, and it's just integrated. So I thought it would be a good idea to take to Nigeria as well.
Thank you.
When we're thinking about mainstreaming.
Thank you.
Thank you.
Thank you so much. My name is Banele Zwane from Eswatini. Thank you so much for the presentation. That was very informative. I got some very creative and innovative ideas on how to basically lead the community into taking charge of their own HIV treatment management. I just have two questions. One is related to the sustainability of the transport stipends, because I am surely thinking that's a short-term thing. Well, one thing that I've heard before and that I think maybe could work, I'm so sorry, I think the mic is close to the speaker, that's why it's making that sound. I'm worried about the sustainability. So I have seen other groups where in far-off rural areas, they come together and they have refill representatives. So instead of all of us in the community going for the refill, we're going to give one person transport reimbursement to get the medication for all of us. And in those same groups, maybe for populations like the sex workers, you find that they have savings groups where they save approximately, I would say in Ghana cedis, 5 cedis. Probably a week or a month. That is just an open sort of bag, maybe all mobile money, that will be available for such needs when someone needs to rush to the hospital. But in condition that whatever amount you take, you work hard to put it back so that it's available for the next person in the group. So I'm thinking maybe to strengthen an idea like that in terms of sustainability and helping the community take charge of their own interventions could really, really help. Probably also making partnerships with the organizations that do have mobile clinics, because they do get into these remote areas and they are funded. So yes, it might also not be sustainable, but it would help relieve the pressure of the financial pressure that they already have. And then my second point was on the lost to follow up patients. I know it is very, very difficult that you can track some people that just disappear off the radar, but maybe I think that's something that everyone should be thinking about, because I think even in my country we have that problem. How can we strengthen our exiting process or transitioning processes, maybe from one clinic to another or from one program to another? Because I don't think it's safe for us to say, 10 people are lost and we really don't know where they are, but they are still HIV positive. I think that's also part of the prevention sort of strategies that we need to look into in ensuring that lost to follow up can stay lost to follow up. Thank you.
Thank you very much for sharing. Any other feedback, questions? So I'll just comment on this feedback and then move on. Okay, so mainstreaming training for healthcare workers have been tried in Ghana. So yes, I do believe that is a wonderful case study that we can adopt, basically see their processes, their steps, how they got around from like start to finish, and also it's also one thing to say you are developing a course but then to get it institutionalized as, oh, this is a process which every healthcare worker has to go through would have been like another ball game entirely. So thank you very much for sharing that. That would be a wonderful case study for us to look into. And then the sustainability of the transport stipends. Yes, so like I mentioned, the entire discussion about the transport stipends is not addressing the roots issues which LGBTQI individuals in Nigeria face. So I really loved your feedback on the refill representatives. That is really great. And then the comment about the savings groups where people can basically take out money to go for medical services is also really great. So I do see how there would be refill representatives, but at the end of the day, clients would still need to go physically for like viral load testing, but then that would solve like one part of the problem and then just leave us the dilemma of figuring out how to sustain clients accessing medical health care when they have to come to the clinic for their tests. And then comment about the mobile clinic also, thank you for that. Would look into that. And yes, I agree with there needs to be like better exit strategies for clients who are lost to follow up, because we can't, like you said, we can't just say they are lost to follow up and so they are lost to follow up and there's nothing we can do about it. Yes, so the exit strategies noted, noted, noted. Thank you. Thank you very much, everyone. So, okay. Okay. Good afternoon. Good morning, everyone, again. So, I'm just going to briefly introduce the next speaker, who is Dr. Ughweroghene Omo-Emmanuel. So Dr. Kingston Omo-Emmanuel is the National Clinic Laboratory Program Officer, USAID in Nigeria, co-chair to the PEPFAR Nigeria Laboratory Technical Working Group, and member of the National Laboratory Technical Working Group and National HIV Laboratory Task Team. So Dr. Kingston has a wealth of experience from his previous roles, including positions at Family Health International, FHI 360 Nigeria, the Center for Integrated Health Programs in Nigeria, and the Mailman School of Public International Center for AIDS Care and Treatment Program in Nigeria. Welcome. Thank you.
Thank you very much, my sister. I'm surprised. Maybe the moderation can be better anyway. So just a disclaimer first. I was a clinical laboratory manager for USAID. Was not my current position. I am currently in academia. I teach at the Niger Delta Institute for Emerging Infectious Disease at the Federal University of Otuoke, Nigeria. So we are here to look at what we have done in terms of cost analysis of load testing in public and private laboratories. A little study we conducted in Nigeria. Again, I'd like to also add that this work was done by the now defunct, with funding from the now defunct USAID, and this work was done by one of our partners, FHI 360 in Nigeria, in collaboration with the SCAP, which is an arm of the Federal Ministry of Health in Nigeria. Next slide. So these are my co-authors. I don't need to mention them. Maybe we'll take next slide so that we'll actually delve into the work. As you know, HIV testing is a very important aspect of HIV. Viral load testing is a very important aspect of HIV management. Without viral load testing, we are not able to know if someone is doing well in terms of treatment, effectiveness of the treatment. And if we don't also do viral load, we are not able to know whether we are doing well in terms of the UNAIDS 95 targets by the year 2030. However, for us to be able to carry out HIV viral load testing, we need laboratories to conduct those viral load testing, and of course other testing, but most importantly, this is the monitoring test, the viral load. And not just having the laboratories, you need to have an adequate number of laboratories. And not only the adequate number of laboratories, you need to ensure that the services are also closer to the people. However, in Nigeria, most of our viral load testing are conducted in laboratories that are in public laboratories, meaning that they are government-owned, and in most cases, they are in tertiary institutions. So it's far away from the people to some extent. You have to move samples several kilometers to get to those places. But there are also some people who are interested in just walking into a private laboratories and say, oh, I want to get my testing done. And they know their viral load testing within a short time, and they go without the public getting to know that they are HIV positive. I recall in those days we used to even collect samples in people's cars because they are celebrities that do not want to be seen that their samples are being collected. So that is why we now said, what are the challenges that these public laboratories are facing? There are many of them. but we have inadequate human resources, and we're all Africans here. I'm not seeing anybody anyway. Your color does not determine where you're coming from. But you discover that there are places you go to, and healthcare workers are living every day for greener pastures. And so that is increasing the workload for the few that are available in those laboratories. Also, the laboratories that are available process large volumes of samples. Some of them hundreds of thousands of samples on a daily basis. And you know, if we are to somebody conducted a study recently and discovered that the burnout rate among healthcare workers is very high because the workload is more. In fact, what I've observed is that those who work in the laboratories actually stay for a longer period and even suffer more burnout than most of the other healthcare workers, especially those who conduct viral load testing, because molecular testing takes a bit of time. Also, we have cases of delayed equipment downtime, and apart from the equipment downtime, you have critical infrastructure that are needed and requires a lot of funding that the government of the United States tends to fund. But now that we're talking of sustainability, is that the way to go? We need to think of how we can get better infrastructure without necessarily depending on donor funding. Also, some of these laboratorians have to work on weekends and after hours testing, meaning that if they are supposed to close by 4 p.m., they are supposed to stay till maybe 8, 10 p.m. And for them to stay, they needed to be paid some stipends. And for that stipend to be paid, it means somebody needs to fund it. But that is not the case with private laboratories. It's quite different because the arrangement is different. Then we have issues of occasional reagent stockouts and equipment downtime. So, going forward, we also know that as part of COVID, a lot of private laboratories acquire very high throughput, functional molecular capacities. But after COVID, with no testing being done, some of them are what? Just dormant, lying idle, right? And another reason why we decided to do this study is we have limited data that compare the cost of testing in public laboratories and private laboratories. So we are not able to say, okay, what is the actual cost of conducting a test in private laboratories? Again, it's even difficult for us to say what is the actual cost of conducting those tests in public laboratories. So that's one of the reasons why we decided to do this work. And because we know that if we understand these differences, it will help us to plan, especially now that we are talking about sustainability of the program as time goes on and with what has happened from the beginning of this year. And like I said, this work was funded by the now defunct USAID in collaboration with the government of Nigeria, the Federal Ministry of Health, and it simply allowed us to leverage a private laboratory that has the molecular laboratory capacity to test viral load, to conduct some samples, to address the challenges that we mentioned earlier on. And this was done between June 2023 and September 2024, even though there was a gap in between. At the time, we had to stop and restart. So, what did we do? We have a state in northeastern part of Nigeria called Adamawa State. And so samples were collected from these health facilities. But before this study, those samples were moved about 800 kilometers to a laboratory in Abuja for testing. So one of the things we did was to say, okay, can we look around Adamawa State and other surrounding states to know if there are private laboratories with molecular capacity? So we had to conduct assessment of private laboratories. One of the issues was that we couldn't find any in Adamawa State and we couldn't find any in a neighboring state. So we only found a private laboratory with molecular capacity in Abuja, which is the capital of Nigeria. And that is Zanklin Medical Center. And so these samples were collected from Adamawa and shipped. Now in Nigeria also we have a national integrated specimen referral network that moves samples, HIV samples, TB samples, NCDs occasionally and all that for testing. in this case, we also did not use the NISRIN, the Integrated Sample Referral Network. We used a private logistics company to move the sample so that we're able to assess this. And what we now did was to now do a retrospective activity-based comparative cost analysis of what is the cost in a private lab and what is the cost in a public laboratory. So we got cost from one of the public laboratories called University of Maiduguri Teaching Hospital. Again, it's also in the east of Nigeria, to compare both of them. And the data we collected were basically on total HIV viral load cost per client. We also look at the cost, that is, looking at the total cost, we look at labor, cost of labor, we looked at the cost of supply, and we looked at the cost of equipment. And when we're talking of cost of equipment, it was with a focus on the cost of the HIV viral load testing kits. And like I said, this testing was done, so we collected the data from Zankli Medical Center in Abuja, which is the private laboratory that participated in the pilot. And we also collected data from University of Maiduguri Teaching Hospital, which is a public laboratory that conducted this testing. And we entered this data into Excel. We had to clean it to make sure that everything was fine. And we analyzed. And what we did was to express the results in United States dollar and in percentages. So let's see what the lessons we learned. We found that the total cost per client in a private laboratory was about 8.13 US dollar. That is $8.13 per client in a private laboratory. And this cost, it was twice nearly the cost for public laboratories, which is about $4.133. And another thing we found that was very interesting is that in both settings, we discovered that the bulk of the largest share of the cost came from the supplies. That is, the supplies that are used for the testing. And we discovered that for private laboratory, it took about 98.7% of the total cost. And that amounted to $8.03 US dollars. But for public laboratories, we discovered it was 95.3%, which amounted to 4.13 USD for the public laboratories. And we're going to talk about this as we go on with the lessons learned. Another thing we found out was that the amplification kit, that is the kit that is used for the viral load testing, cost 5.85 tests, US dollar per test, in the public lab. But this is almost double the amount in the public lab, which was 2.78 USD in the public laboratories. And we also noticed that there was a significant cost difference between the two sectors. That is the public laboratory and the private laboratory, if you look at what we have seen in the first three bullets. Now, another very interesting thing that we saw was that labor and equipment costs were lower in the private laboratories. So, meaning that the cost of equipment and labor was higher in the public laboratories. And this can be because of the setting in public laboratories. You require people to run shift or call duty. You require to pay them extra money for weekends or after hours and all other things. And also, the level of equipment you have in most of the public laboratories where molecular testing is done is much. In the public lab compared to the private laboratories. In fact, one of the things we see in private laboratories is that one or two persons can actually do the testing compared to the number of people we see in the public laboratory. So that affected the cost of labor and equipment in private laboratory being lower. Now, but if you look at the cost of supplies for both laboratories, you see that it is higher in public laboratories. So we now try to find out why was it higher in private laboratories. And we discovered that It is simply because private laboratories benefit from global price negotiations. So we had a global RFP, request for proposal, that was done, and we used that price to procure, for public laboratories. However, and also when the reagents and the equipment come in country, they also are not subjected to duty waiver. So there's no duty waiver. However, the private laboratories will buy at the prevailing market rate. So they do not enjoy the global price negotiation, and they also pay import duty for the commodities that they bring in country. And this one that was removed from the public laboratories actually reduced the cost in the public laboratories. So that is why we are having the cost being lower in the public laboratories compared to the private laboratory. Next slide, please. So what are the next steps? We are recommending that, based on the analysis that suggests that the majority of the cost for HIV testing being from high expense of supplies, there is the need for cost optimization strategies in this area. Meaning that one of them is to ensure, for instance, that the private laboratories can benefit from the duty waiver that the public laboratories are benefiting from. And also, the private laboratories can buy from the vendors at the same rate that the public laboratories are buying. That is, the numbers from the private laboratories should count towards the volume for each country when they are buying. Meaning that if we are negotiating with vendors and we say the number of tests we are going to do is 100, and we know that private laboratories are making contributions, we should add those numbers so that when they are procuring, they are procured at that reduced price. Also, these findings underscore the importance of strategic resource allocation and cost control measures to expand access to HIV viral load sector, in both sectors. Now, what we are trying to say here is that the time has come for us to begin how we can make cost more affordable so that people can go to all those private laboratories. We may not need to begin to continue to depend on only the public laboratories. There's the need for us to make the private laboratories functional so that people can go there. Because where we are now, we are talking of sustainability. And one of the ways we can sustain the fight against HIV is to make sure that people can actually go to private laboratories to get tested, have their viral load samples collected, tested, and they get their result. And another component of the work we have not shown here, and which is still being presented somewhere, is that we have also looked at even turnaround time, and we saw very favorable turnaround time, even in the private laboratories, meaning that you could actually walk in and get your result within a short time without those processes. And it reduced the need for moving samples several kilometers, right, for testing. Meaning that if I have a lab close to my area, I should be able to go there rather than allowing my samples to travel several kilometers, at times up to 1,000 kilometers for testing. So we recommend that we should optimize private laboratories to contribute to the fight for HIV. And another way is to also ensure that not for only HIV, because their cost is going to be integrated testing because they use those equipment for some other testing, you're also going to benefit by the time you optimize the use of private laboratories for HIV testing. So that is the work we have done that we said we should share, and hope that we are able to scale this up in my country, Nigeria, and we are hoping that other countries that are here are able to also pick this up and see what they can do in their own country as part of the sustainability drive that we're talking about in Africa and all over the world. Thank you very much for listening. So if there are questions, we can quickly take them. Yes, please.
Thank you very much for the beautiful presentation. My name is Ishmael from Malawi. I have a number of questions. I don't know if I'm permitted to ask all of them, but
I don't know if there's any other presenter here, and it's actually supposed to be 10 minutes, but if time permits, yes, it would be good for us to.
okay. So the first question is, I just wanted to have an understanding of how some public issues, including the civil that is in some other parts of Nigeria, has affected the effort. That's my question. And the other question is, I didn't get it from you about who is paying for the initiative. And the other question is, I also want to have an understanding of the measures that have been put in place to make sure that the private facilities or labs are not abusing the so-called procurement waiver. And lastly, according to the distances that you mentioned during the research, I think there was only one lab that was identified. How do you think that that helps the situation, considering that it's only one molecular private lab that was identified, and still more we should expect the issues of the labs being overwhelmed with the tests? How did you, or what are you planning to do about that? I'm considering the turnaround time as well as the safety of the samples, considering that these labs will be overwhelmed. I remember hearing you mentioning about a radius of about 800 kilometers, which is a very big distance. Thank you very much.
Question this side? Question this side? Yeah. Yes. Just a question from my end. Thank you so much for the presentation. I just want to find out what kind of public-private partnerships have you guys established? And this is your relationship with regards to, private laboratories. Sorry, I didn't even introduce myself. My name is Ughweroghene from South Africa. So the thing that we have managed to crack very well is the benefit from the private sector, because we've got that particular MOUs, those agreements where we can also benefit from some of the deals that they have with the vendors. So I just want to find out if maybe that is an area that you guys have explored. Secondly, just to slide off the topic for a second. So maybe we normally have medical practitioners who have their own private practice, right? And they're diagnosing the HIV patients there. But in most cases, you find that these are the same staff members that are working in the public hospitals. So whenever they request samples to be conducted that they got from patients in their private practice, they request that through the public hospital to a public laboratory. So I just want to find out if maybe you've got encounters like that, and perhaps how do you deal or help deal with those kind of situations? Thank you so much.
Okay, yeah, thank you very much, Dr. Kingston. My name is Otuoke, and I work with Heartland Alliance in Nigeria. I wanted to find out if the location of the private hospital contributed to the difference in the cost. I don't know if you look at other possible or potential co-founding variables, because in Maiduguri, the cost of living in Maiduguri would be drastically different with the cost of living in the FCT Abuja, where Zankli Hospital is. So I wanted to know if you looked at those possibilities. Thank you.
All right, thank you very much, Dr. Kingston. My name is Dr. Paul Lumo, also from Heartland Alliance, Nigeria. Mine is just a comment, beautiful presentation. I just want to find out if this kind of research could be extended to include hospitals also that are public, private partnerships, so that we can also compare this kind of costs. Since we have the public, we have the private, and we also have hospitals there in Nigeria that are public-private partnership. Thank you.
My brother from Malawi, I didn't get your first question, but I think I got the other one. The second question is, who is paying for the initiative? Yeah, so good question. The study has ended. It was funded by the United States Agency for International Development, USAID, now defunct. So it's not an ongoing study. It's something we've done and has been concluded. And we are hoping that our Federal Ministry of Health, who are ably represented here, will look at the possibility of, getting to implement further or scale it up if they find it satisfactory. Now, the other one was how to prevent the public or the private laboratories from abusing the waiver. So the way the waiver is done is that it is specific for the commodities. So for you to get a waiver, it has to be specific commodities that you are submitting. So if I bring in amplification kits, I am going for the amplification kit. You cannot use it for other commodities or reagents or drugs that are not part of the waiver, because this is controlled by the National Quantification Team together with the Ministry of Finance and other agencies of government that are controlled. So it's difficult to abuse. However, people can be very creative, and I'm sure that government has a way of getting that done. And let me also tell you that even for the donated ones that goes to the public laboratories, they are also well checked to make sure that that does not happen. So that is taken care of. You said only one lab was identified. Yes, so this study was done in one state. Initially, we wanted to do it in 3 states, but we restricted it to one state so that we don't use the little resources, scatter it all over the place, and we don't achieve much. So we wanted a lab that could serve that particular state. That's why we identified one. However, there are many laboratories, private laboratories in Nigeria that have the capacity to conduct HIV viral load testing. Like I said, many of them procure those molecular platforms during the COVID. And so those ones are now lying idle. And in fact, when they learned that we are doing this study, in fact, this morning, I still got a message from one of those private laboratories asking me, when are you coming to our laboratory to do the same study? So there are many. And they are spread all over the country. And they actually assisted to a large extent in our fight against COVID. And that we won very, very well. And our testing was very well. For my brother, you talked about the PPP framework. Yeah, so based on this work, there was a component of this work that was done after this one, was to now set up a public-private partnership framework with the government of Nigeria. We started something, again, you know what happened in January, a lot of things had to be put to a stop. But I know that work is still ongoing by the Nigerian Center for Disease Control. Because this time around is not only for even HIV services, but covering even other priority diseases. So that is being done, and we are hoping that that will be concluded and become part of government guidelines, as the case may be. And you also ask about how the private laboratories can benefit from the global RFP. And like I said during the presentation, it's just a matter of putting their numbers, adding their numbers to whatever the country is procuring. Because what determines how much you pay per country is the volume of testing you are able to do. If there are, what's that term they use now? There are different targets or milestones you must meet. If you are unable to meet that target per year, the amount you are going to pay or the cost per test may go up. If you are able to meet it, they will take you to a higher test. So, yeah, it's just to add these private laboratories to part of those that will benefit from the global RFP and using their numbers, and they can procure from those vendors using that amount. And my understanding of what we did when the global RFP was done was to make sure that everybody actually benefit, so that if I go to the market, I buy at the same rate. Not that if I go to the market, I buy at the same rate. My brother here goes to buy at a different rate. Countries for public laboratories are already enjoying that. It's just a matter of now making sure that we also add the private laboratories to that. You talk about samples collected in private laboratories going to public laboratories for testing. As part of this study, we actually made sure that there was proper monitoring. And even before that, there was an assessment that was carried out. We gave them the basic requirement, and we were monitoring to make sure that does not happen, so that they don't move those samples. And in this case, this is a private laboratory that does not, have that kind of relationship with the public laboratory. But during the course of this study, no samples actually leaked out to the public laboratories. And we also collaborated with the vendor to make sure that we're also tracking whatever the number of reagents that they are buying, that is actually agree with the number of tests that they did. So we didn't encounter any case of samples going to the public laboratories for testing. The question by, I think that was Dr. OBB, location contributing. Yeah, so the areas we looked at now is not necessarily the cost of what people are paying, but we come and say how much you spend on diesel, for instance, how much did you spend on reagent and all that in the private. And that form, because during the assessment, we give them, it was an RFP, so they came and submitted their quotation, and we went for assessment, and we compare cost for each of those laboratories, which is one of the components that guided the decision to use Zankle Laboratories. Now, for the public lab, which is in Maiduguri, we did not use directly getting it because the procurement was done by the PSM on behalf of the US government. So we could get those data, and it's the same amount that you have in Maiduguri, that you have in Lagos, that you have in Abuja, anywhere. So that is this thing. So the cost did not, and as part of doing this study, like I said earlier on, we also involve even the vendor to make sure that to some extent there was an adjustment so that we do not really have that kind of high rate. The only thing is that they did not enjoy the global RFP price for Nigeria, and they did not also enjoy the duty waiver. That is the only difference. So the location did not affect the cost. Inclusion of public-private hospitals in this study or in subsequent work. Yes, the study has ended, and thank God, like I said earlier on, our very senior officials from the Federal Ministry of Health are here, and they are listening. I'm sure that if they need to take this further, they are going to consider those public-private hospitals in the scale-up and all that. And like I said, this is something worth doing as part of the sustainability drive. And when that time comes, the negotiation, especially as part of the bilateral agreement with the United States government, these are things we should consider as part of the sustainability. Thank you.